thank you for joining us in this conversation about the role of national organisations and initiatives in addressing health inequalities. I'm Amanda Begley, National Director of the NHS Innovation Accelerator and Director of Innovation and Improvement at UCL Partners. And I'm joined by Dr. Bola Wilabi, who's the Director of Health Inequalities at NHS England and Improvement, and by Deborah O'Callaghan, who's the Associate Director of the National Institute of Health and Care Excellence. And we've come together today because, as we all know, addressing health inequalities in terms of access, experience and outcomes is a major focus for the NHS, especially as COVID-19 has had such a disproportionate impact on many of those who are already facing disadvantage and discrimination. NHS England, Improvement, NICE and the NIA are working together to share our thinking, to test ideas together, to learn from each other, so that we can best understand how we can help the NHS and innovators in their efforts to tackle health inequalities and to protect those at greatest risk. So the aim of this session is to share some of our current plans and our insights, and we're really keen, as this is broadcast at the NHS Confed, that we get your feedback and in your involvement. So to begin with, I'd like to ask Bola to give us an overview of the work that she's leading at NHS England Improvement to address, understand and address health inequalities. Thank you, Bola.
Thank you, Amanda. Thank you for the invitation. It's great to be here. Over the last several months since arriving in this role in NHS England and Improvement, I've had the pleasure of speaking with several individuals, teams, organizations right across the country. And I believe that the vision that we've set out as NHS England and Improvement around tackling health inequalities is genuinely the distillation of the voices of many. And therefore, I think that is where the power of this vision sits. What we've come up with is what we're trying to do together is to deliver exceptional quality healthcare for all. And the emphasis is on for all through equitable access, excellent experience, and optimal outcomes. And we set this within the context of the pandemic, because of course, if we look over the last several months at the various reports and publications that have come out, whether that is from Public Health England, from think tanks like the King's Fund and the Health Foundation, the ONS, one thing that we can see quite distinctly is that the health inequalities that have existed in our communities prior to the pandemic have been exacerbated by the pandemic and made even more obvious. And so one can rightly draw a conclusion that our greatest legacy from this pandemic needs to be narrowing health inequalities, not because they're new, but because they're now front and center of our consciousness because of the harsh light that the pandemic has shone on them. I'm also mindful that in doing so, we must do so as a collective. I recognize that a single team within NHS England and Improvement, i.e. the Health Inequalities Improvement team, is not going to be able to make the quantum change that is required in narrowing health inequalities as a standalone entity. We must do so in collaboration with other organizations across the NHS and indeed beyond the NHS. And I describe these very much as the enabling programs. So working in collaboration with our colleagues in primary care, our colleagues that are focused on prevention, people in the personalized care space, our community services, our voluntary sector partners, public health, population health, and particularly integrated care systems. So as we go forward, recognizing the important contribution that integrated care systems have to make in the health inequalities space, and us being proactive in working with them. And so when we talk about the communities affected by health inequalities, I often describe those populations and the lenses through which we're looking at them. So we're talking about ethnic minority communities. We're talking about people living in the most deprived areas of the country, people that we often describe as the inclusion health group, i.e. those experiencing homelessness, our traveler communities, indeed people living with learning disability and or autism, those experiencing severe mental illness, and of course, people with protected characteristics. And it's important to recognize that we're looking at all of these populations, all of these communities through two lenses. One is the lens of disease, whether that is cardiovascular disease or diabetes or any other sort of life cause conditions, but also through the lens of the wider determinants of health, because we recognize that to look at these communities purely through a disease lens is to miss the bigger drivers of inequality, i.e. education or the lack thereof, income or the lack thereof, housing, and those important determinants that we've traditionally described as the wider determinants of health. And just to be clear that the NHS has a very powerful contribution to make to tackling health inequalities as a commissioner and provider of services, as a key partner within the integrated care system, as an anchor institution in its own right, and indeed as an employer of 1.3 million people who are actually a microcosm of the communities that we serve. Over to you, Amanda.
Thank you so much, Bola, setting out such a clear vision, a reminder that we need to take a broad definition of health inequalities beyond disease, and that this really is a call for a collective effort if we're going to deliver on the ambition. I'd like now to hand over to Deborah to give us an overview of the work that NICE is undertaking.
Thank you for inviting me to join you, Amanda and Bola. The core purpose of NICE is to improve health and well-being by putting science and evidence at the heart of health and care decision-making. And reducing health inequalities has very much been a long-standing focus of NICE's work. It's enshrined in our principles, our processes, and our ethos. For example, we have a set of principles that guide the development of NICE guidance and quality standards. The first one is about preparing guidance and standards on topics that reflect national priorities for health and care. And when we prioritise our topics, we consider the impact on health and well-being, including variation in current service provision, and also the potential to reduce health inequalities. Engaging with people with lived experience is absolutely essential. And our fourth principle is about supporting people who use services, their carers and their families to become involved in the development of NICE guidance, regardless of language, disability or other potential barriers. And we have some really good examples of co-production, for example, with our learning disabilities guidance. We launched the new 5-year strategy for NICE in April this year, and it outlines a renewed determination to prioritise our work to reduce health inequalities. The strategy is built around 4 pillars, and reducing health inequalities is very much a cross-cutting theme throughout those pillars. So the first pillar is about rapid, robust and responsive technology evaluation. And our new flexible methods and processes will include focus on inequalities. The second pillar is about dynamic living guideline recommendations that will support work to reduce health inequalities. The third pillar is about supporting effective guidance uptake to maximise our impact and ensuring that we support the reduction of inequalities through implementation. And the fourth pillar is about leadership in data, research and science, and supporting the use of real-world data so that we understand where inequalities occur, and also how implementing NICE guidance will impact on people in the real world. So how will it create or reduce health inequalities? In order to oversee the huge amount of work that we have underway, we have established a cross-institute group, And they're working to identify, prioritise and progress opportunities to do more to embed consideration of health inequalities within our work and implementation support. We're also engaging with the health and care system to ensure that we're providing support where we can best add value. We have several projects underway. One of them is around developing a more rigorous and systematic framework for identifying and considering health inequalities throughout the guidance development process. So this includes an improved approach to equality impact assessments as part of guidance and quality standard development. We're also collaborating with academia, and we're working with the University of York to develop a prototype equity impact calculator, which will support the consideration of the impact of specific technologies or interventions on health inequalities. We're engaged in work with system partners in health, public health and social care to support local work on health inequalities. And this will help us to obtain intelligence on where NICE can best add value. We're also ensuring that we're building good health inequality focused relationships with key system stakeholders and partners, as partnerships and collaboration will be crucial to taking this work forward.
Thank you, Deborah. It's really helpful to understand how health inequalities is running throughout NICE's work, and particularly around the involvement of users and families and co-production and your work on equality impact assessments. I just wanted to say a bit about the role that the work that the NHS Innovation Accelerator is undertaking. So for those that aren't aware, the NIA aims to support the adoption and spread of high impact innovations across the country, and also to capture and share learning. In terms of the accelerator, what we're really focusing on is defining and executing our role in how we identify innovations that tackle health inequalities, and also how we support innovators to understand their role in supporting the NHS to address the needs of those at greatest risk. So our programme currently has 4 main strands to it. The first is around how we build our network and community to ensure that we really are feeding in a diversity of views and experiences into both our application and selection process, and in also how we help our innovators to further develop and refine their innovations so they are inclusive of the communities that they're seeking to benefit. The second area is around reviewing our processes. So we really need to ensure that our recruitment and selection processes really promote equity, including things like how our NIA call is advertised, how it's promoted, how candidates are shortlisted and interviewed, to ensure that we have as equitable an approach and as wide a reach as possible. The third area, which has already been touched on, is health equity assessment. So we want to support our fellows to undertake assessments of their innovations, to really understand, anticipate and to overcome any barriers to access and to take up of their innovations. And we want to support their efforts then in making any improvements that they need to make in order to ensure that they can, through their innovations, support equity and access and experience and outcomes. And the final area is really drawing on the evidence base. So we're starting 2 literature reviews. One is to identify what are some of the amenable factors within the NHS that could potentially reduce health inequalities in England. And we're focusing on the 6 populations that Bola had talked about earlier. So ethnic minority groups, homeless population, traveller communities, individuals with learning disabilities, individuals with autism, and those with severe mental illness. And if you would like a copy of that, please do come to the NIA stand, which is in the HSN network feature zone. And the second literature review, which we'll be happy to share later in the year, is really to understand how we target health inequalities in the adoption and spread of innovations. So not so much around the design and development of the innovations, but how they're actually implemented in practice to ensure that they are inclusive and accessible for all. So that was, we've given a bit of a summary on where we are at in terms of our planning, and now we wanted to have a bit of a discussion where we can share some examples and some tips and some real world examples where we feel health inequalities have been really prioritised. Just to start off with, can you give us some real world examples where you feel that health inequalities have been really prioritised? And maybe I'll start with Deborah.
Well, thinking from a perspective of producing nice guidance and quality standards, we have a couple of examples that immediately spring to mind of where we've had differential recommendations for particular groups of people. For example, in our tuberculosis guideline and our smoking cessation guideline, where we highlighted particular population groups that are at higher risk. We also have specific quality standards. For example, there's one on promoting health and preventing premature mortality in Black, Asian and other minority groups. So we do have some real examples of specific guidelines and quality standards. But thinking more about how we've actively supported an organisation to think about how they address health inequalities and thinking about innovations. Our scientific advice service prompts developers to consider health inequalities and to reflect this in their evidence submissions. So when they put forward the evidence to enable us to undertake the appraisal. And there was a recent example for a dermatology treatment where there was concern that the trials hadn't included enough people with different skin colours. So the developer was advised to expand the diversity in their trial and to consider how to present the findings to the committee. And it's interesting to note that our scientific advice service includes people with lived experience, and it was actually the lay representatives of the committee that highlighted this for us. So it really shows how lived experience broadens our understanding of where there are likely to be inequalities and where there are likely to be issues. And I just thought that was a really good example.
Thank you, Deborah. Bola, would you like to?
Thank you. Absolutely. So yes, I'm just really pleased reflecting on the fact that last July, the NHS published the phase 3 pandemic response letter, in which we outlined the 8 urgent actions for tackling health inequalities. And it's great to see how those 8 urgent actions have actually played out in real life. The first example I will give is when we talked about restoring our services inclusively. And we asked organizations to look at their waiting lists and not just look at them purely on the basis of clinical prioritization, but actually consider what those waiting lists look like for different population groups. And it's great to see Calderdale Trust. People may have come across it in the HSJ on Friday, where Calderdale have proactively prioritized people with learning disability on their waiting list. And I think that is a very powerful example of where, a strategic priority that we've set nationally has translated into real life practice at the front line that will make a real difference in people's lives. Another example that really heartens me and many people is when we talked about accelerating preventative action around people most at risk, particularly in terms of the vaccination program. And it's great to see how the NHS COVID vaccination program very proactively involved the voices of communities, such that we are now at a place where, although the uptake rates amongst Black African communities, Bangladeshi, Pakistani, we can still do better, but actually it is a great story of how that focus has translated into real improvement. So back in January, February this year for Black African communities, we were at about 38% uptake. We're now at around 70%. And we're not being complacent. There is still way to go. But that is an example of how we have prioritized health inequalities as part of the COVID vaccination deployment program with great effect.
Fabulous, thank you. Just to give a couple of examples from the NHS Innovation Accelerator, but you will hear more tomorrow on Thursday at 2:30, where we've got some of our fellows sharing their experiences of how they have adapted their innovations to meet different populations. So you've got examples like AccuPebble, where they were finding that people were having to spend time off work to go and get their sleep apnea assessed and diagnosed. And actually AccuPebble provides the opportunity for people to do that test at home. They provide a mobile device for them. It can work offline, so they don't require internet at home. And so they've been really thinking about how they make that service much more accessible. Some of our other services like Vine Health found that individuals really wanted their carers to have logins to their cancer support services, because they were very much part of their care journey. And the low carb program was finding that actually family members were logging on for their elderly relatives. And then they realized that actually they needed to make the service much more accessible, particularly to the South Asian population, and to make sure there were additional languages available, and they make sure that they were allowing that population to feel more confident in using the platform directly rather than relying on their relatives to participate. But you will hear more on that tomorrow. The second question I've got is, are there one or two practical tips that you might offer to either providers or innovators or commissioners to really focus on when they're looking at how they might consider health inequalities in their work? I'll hand over to Bola first, sorry.
Thank you, Amanda. So practical tips, again, just reflecting on the learning from the pandemic. I think taking a hyper-local approach to service design and delivery is really important, because the communities that we serve often have the best, most creative, most sustainable ideas of how we can configure our services. So, for example, talking about the vaccination program again, the fact that we realized that for many of our communities who struggled with confidence in the vaccines, many of them had a strong faith element to their identity, as well as a strong sense of community. And that realization and having conversations with those community leaders and those faith leaders led to a different offer. So the pop-up centers, the places of worship, all of those alternative delivery models that have really driven the uptake in the way that I was talking about earlier on, for me, speaks to the importance of taking a very hyper-local, community participatory approach to the design and the delivery of our services. And my second tip will be the power of data. Somebody said to me, once you see the data, you can't unsee it. So my second tip will be, cut the data in a way that will help you see where the disparities lie. So whatever data sets we collect currently, let's cut them along the lines of the population groups that we've just been talking about in the introductory section. And by so doing, it focuses us on where we have disparities, and it guides the conversation about the interventions needed in order to bridge the gap. So essentially, create virtuous circles whereby data gives us actionable insight. Those insights then drive meaningful intervention. And from those interventions, we can derive intelligence about what works. And we keep doing what works and stop doing what doesn't.
Thank you, Bola. And Deborah, did you want to share?
So my top tip for providers would be that if you provide care in line with NICE guidance, it will help reduce inequalities in experience and in outcomes, but also to highlight the NICE quality standards, which summarise high impact improvement areas for a topic. So where we know that there's inequalities or unwarranted variation, we highlight those as priority areas for improvement. So flagging those, but also top tip is that we have a guideline on shared decision making coming out later this month. And there is evidence that shared decision making with people helps mitigate where there are some inequalities, for example, in health literacy, so education, understanding, and it can also support people with agreeing a care pathway that they can fully engage with, and that so that they're able to follow their treatment plans, and so they can benefit from better outcomes and a better experience. So I'd flag that. For innovators, I'd just say that efforts to address health inequalities will be recognised. We've been working collaboratively as organisations already on evidence standards for digital health technologies, and also we're working on a set of evidence standards for artificial intelligence, and both of those outline specific expectations about how health inequalities are considered, about the transferability of the data that is being used to inform artificial intelligence and so on. So do think about it and it will be recognised. And just briefly for commissioners, absolutely community engagement was going to be something I was going to mention. And also if you are taking a population health management approach where you're looking at specific population groups where outcomes aren't as good, or where there's reduced access to services or treatment, do know that once you've identified your population groups, again, NICE guidance describes evidence-based interventions that will help you to address those. And just some examples might be around improving access to physical health checks for people with mental health illness, access to annual health checks for people with learning disabilities, right through to oral health care for people in residential care. So where we know there are inequalities, NICE guidance can help you to address those with evidence-based interventions.
Thank you. I would just highlight from the literature review that we've just done is the need to think about how, take into account how inequalities can be sort of overlapping and converging. So rather than I suppose we need to make sure that we're thinking about understanding someone's entire experience as a whole, rather than seeking to address individual inequalities, because somebody's disability, for example, they may find that their ability to access services is also greatly reduced by their gender or their socioeconomic status. So making sure that we're thinking about people in their entirety rather than siloing different inequalities. And then to wrap up, I just wanted to ask briefly what you would love to be different in a year's time in terms of how we approach health inequalities. And I'll start with Bola.
Thank you, Amanda. So in a year's time, what would I love to be different in how we address health inequalities? I think I would like us to have adopted universally a quality improvement approach that utilizes 3 key quality improvement approaches. One, as I said before, is using data for improvement, not just using data to provide assurance. The second is making sure that we genuinely co-produce with the communities that we serve for all the reasons that I outlined earlier on. And the third approach is the strengths-based approach, whereby we recognize that communities that experience health inequalities do have a lot of strengths and a lot of assets. And we need to inquire into those strengths and not assume that the totality of their experience is health inequalities. So I think for me, in a year's time, wonderful if we are in a place where universally it's a quality improvement approach data for improvement, co-production with communities, and strengths-based conversations.
Thank you. And Deborah?
I really like that future. My reflections really were, I'd like consideration of health inequalities to be embedded in all that we do, and for it to become natural to consider where there might be health inequalities and what we could do to overcome them, but to do it with transparency so that people can see what we're doing to consider health inequalities and what actions we're taking to try to address them, but being open to always trying to do more, to always look to see where we can take more action, where we can work more closely together, where we can have more impact, and just constantly striving to be committed to really taking action on health inequalities.
Thank you. I think I'd just like to end with a personal experience from this year, where my sister, who has severe learning disabilities, has, I think, been subject, unfortunately, to diagnostic overshadowing. She's been suffering from tremors that have come from nowhere, and she's been discharged saying that there's no further investigation. These tremors are clearly to do with her disability, and there's nothing we can do. And 5 months later, having just earlier this week seen our third neurologist, who said that these tremors could actually be epileptic. They need to be investigated as a matter of urgency because they might be causing some damage, and we need to get her on treatment because her quality of life is poor. So I think I'd like in a year's time for us to not be making assumptions and for us to continue to be curious and eager to learn. So I'd just like to say a huge thank you to my panel for sharing their insights and experiences. And I think I'd probably go back to Bola's earlier point in that we're not going to crack this individually or as individual organisations. This is really collective action. So I'm really keen to have people contact us to learn more, to get involved, but also I'm keen to learn throughout the Confed the work that others are doing so that that can inform our individual programmes of work. Thank you very much.
Thank you, Amanda. Good to be here. Thank you, Deborah.
Thank you.